talk about some of the things that you have to be wary of after a myocardial infarction. So we're going to start off with talking about a left ventricular free wall rupture. So this occurs 5 days to 14 days after a heart attack. And this is usually after an anterior MI of your LAD. And so with this, these patients will often get very hypotensive and tachycardic. So it looks like a cardiogenic shock type picture. And so the blood that leaks out from the rupture into the pericardial sac is going to compress the left ventricle. Then the left ventricle can't fight against that pressure to get the blood out, and so you get hypotensive. And this is super dangerous, and it can result in pulseless electrical activity with low voltage due to cardiac tamponade. So if you see a free wall rupture, just imagine the whole front of the heart just basically ripping out and all that blood going into that pericardial sac, and you'll get cardiac tamponade. And so if you see a PEA, remember the mnemonic, push epi always, PEA. And so that's your next best step. You want to start your ACLS protocol, push epi, and then start chest compressions. All right, next let's talk about interventricular wall rupture and comparing it to the ventricular free wall rupture. So we're talking about the ventricle wall between the left and right ventricle versus the front wall of the ventricle rupturing. And so they both occur most at 5 days post heart attack. But the interventricular rupture is going to cause a VSD, so a ventricular septal defect type picture. And so you have to be able to identify a VSD that you'll see with the interventricular wall rupture versus the cardiac tamponade that you'll get with the free wall rupture. And it kind of makes sense if you think of a heart. Here's your left and right ventricle, and my thumbs are the interventricular wall. So if those rupture, then basically you have a VSD of the blood going from the left to the right side of the heart. And so that's how I like to think about it. And the VSD will present as a loud hollow systolic murmur. And this patient's going to obviously get really hypotensive because the blood's not going out in their systemic circulation. It's just going from one side of the heart to the other. And these patients will have basically immediate heart failure that looks like it's right-sided overload. And it's because all that blood from the left side is going to the right, and the right can't combat that increased amount of blood. Now let's talk about papillary muscle rupture. You also can see that 5 days after a heart attack, but you see it 3 to 5 days specifically after an RCA infarct. And it's because the RCA is going to supply the papillary muscle. And this can also present as hypotension, just like the ruptures that we talked about. And it will present as pulmonary edema with mitral regurgitation. And so this is not as bad as a free wall rupture, obviously, but it still can cause this mitral regurgitation. And so generally the decompensation is more rapid with a free wall rupture than it is with a papillary muscle rupture, and it's also different anatomy. Because remember, the free wall rupture is going to be after an LAD infarct, whereas the papillary muscle rupture is after an RCA infarct. And so the patient in the question stem is going to really decompensate quickly, and it goes into pulseless electrical activity. You think more free wall rupture because it's very, very acute. It's a huge volume of blood that leaks out, causes pericardial tamponade, and these patients get hypotensive, tachycardic, cardiogenic shock type picture. And so that's when you start thinking free wall rupture. And obviously you can die from this. And if you see the term ventricular aneurysm, this is nowhere near as bad as a free wall rupture, but it is still concerning. And so this is going to be weeks to months after a heart attack. So basically think of the walls of the heart just getting stretched out because they're weaker where the infarcted cells are at. And so this ventricular aneurysm, it causes turbulent flow, and you can build up clots in there that can shoot elsewhere into your body. So you can end up getting acute limb ischemia, you can get strokes, you can get end organ ischemia, so you could get like a splenic infarct or a renal infarct. Basically that clot can shoot out anywhere into your body. And so that's something to be aware of with ventricular aneurysms. All right, let's talk about pulmonary hypertension. So you're going to diagnose this when you see a mean pulmonary artery pressure of greater than 25. That's a number you need to memorize. Greater than 25, you're thinking pulmonary hypertension. And so a very common cause of pulmonary hypertension is left ventricular systolic dysfunction. So basically the left side of the heart doesn't squeeze well and the blood backs up into the lungs. And the management of pulmonary hypertension due to left ventricular systolic dysfunction is loop diuretics. That's the number one key. And then you can also add on an ACE inhibitor or a beta blocker or spironolactone. But the number one thing that you should think of is loop diuretics to get all that fluid out of the lungs. And so I remember when I missed this, I actually put the answer bosentan for pulmonary hypertension, because I remembered back from Sketchy that bosentan is one of those medications. It's an endothelium antagonist, and it can work for pulmonary hypertension. But this is idiopathic pulmonary hypertension that you use it for, not hypertension due to fluid overload from the left ventricle backing up into the lungs. So think about the etiology of it. If it's just scarring down of the pulmonary vasculature over time, idiopathic pulmonary hypertension, use something like bosentan. If it's fluid overload, then use diuretics like loop diuretic. You can also use an ACE inhibitor and beta blocker or spironolactone to help with the cardiac remodeling as well. So, long story short, think of the etiology when you have pulmonary hypertension, and don't just trigger answer bosentan, for example, like I did. All right. Another type of cardiomyopathy is tachycardia-mediated cardiomyopathy. And so people that have chronic tachycardia, something like AFib for a long time that's uncontrolled, this can cause cardiomyopathy. And so you can actually get structural changes of the heart, like left atrial or left ventricular dilatation with global hypokinesis. Very rarely is this going to be asked on your USMLE, but it is something that was an answer choice on a question for UWorld, so I wanted to dive a little bit deeper into that. So just know that you can have structural changes of the heart from chronic tachycardia. All right, let's dive into some of the pediatric congenital heart defects. We're going to kind of target these off and on here. I'm going to just give you a few here, and we're going to cover a few more later. And so if you've heard of transposition of the great vessels, basically when they switch, you'll get something called an egg on a string sign, and you'll have a narrow mediastinum. And so you really want to be able to identify that egg on a string sign. If you have tricuspid atresia, then this will present as a single S2, just like the transposition of great vessels, and also just like truncus arteriosus. All three can present with a single S2. And so you can remember the T has two strokes, a horizontal and a vertical for the letter T, and it's a single S2. All right, and then so you also have the total anomalous pulmonary venous return with obstruction. This is going to cause pulmonary edema, and the buzzword for this is the snowman sign. And so this is basically your supracardiac veins and SVC get enlarged and engorged. So if you don't know the snowman sign, pause the video and then go to Google Images and type in snowman sign for total anomalous pulmonary venous return with obstruction. All right, moving on. Let's talk about heart sounds a little bit. So the S4 heart sound should sound like 10 Nessie. That's how it sounds whenever you're listening with the stethoscope. And it's a diastolic sound heard just prior to S1. And that S4, you want to emphasize the 10 Nessie. And so the Nes is S1 and C is S2. And I put this in here to remind myself because when I heard the audio clip, I wasn't able to identify the S4 heart sound. If you guys remember, we talked about in prior video about the S4 heart sound. It can be normal if it's a young patient or a young adult. It can also be normal in an older person if they have a past medical history of long-standing hypertension. And so there's plenty of things that you can see in S4 with, but it's usually due to decreased compliance in the heart. So keep that in mind when you hear the Tennessee type murmur. All right, I wrote down Ranolazine here because this was actually the first time I had heard about this medication. It's used to help with angina, and it's used basically only with chronic exertional angina to help prevent the chest pain. So no Ranolazine can be used for angina. All right, next, let's talk about VSD. Some of the high points for VSD is that it's a holosystolic murmur. You're going to have an apical diastolic rumble in some cases, and it generally presents as a prominent S2 the more the right ventricular pressure increases. And also, don't get confused because mitral stenosis can also have an apical diastolic murmur, but it's not going to be holosystolic like the VSD is. So if you see holosystolic plus an apical diastolic rumble, you're thinking VSD. If you just see the apical diastolic rumble, you're thinking more mitral stenosis. And it makes sense because remember, mitral stenosis, the blood's flowing past the mitral valve during diastole, so that's why it's a diastolic rumble. All right, let's talk about some connective tissue disorders. We have Ehlers-Danlos here. So these patients are going to have very, very common history of joint dislocations. And not just the joints, they can also have weakness in their abdominal wall, and they can have abdominal and inguinal hernias, as well as uterine prolapse. So just think anywhere where there's connective tissue, it's weaker. They're going to get atrophic scars, and so it looks like cigarette paper. It's very thin skin. They can have spontaneous organ rupture. So that could be like your spleen just ruptures out of nowhere. And these patients obviously are going to have poor wound healing, and one of the cardiac findings that you have to know for your cardiology questions is mitral valve prolapse. So that's going to be really common with connective tissue disorder type questions, is mitral valve prolapse. The big difference between osteogenesis imperfecta and Ehlers-Danlos is osteogenesis does not have the joint dislocations. And that's how I got tricked on this question. And so I remember osteogenesis has kind of the skeletal muscular defects as well, but they do not have joint dislocations. But they will have some more brittle bones, they'll have discoloration in the eyes, and you have to be able to differentiate based upon the joint dislocations being present. And so that would be Ehlers-Danlos. All right, let's end it here, and we'll pick up in the next video with compartment syndrome.